The first question has to do with what's the survival rate of myeloma? Can you remind us?
I'll start. I think the easiest way to answer this is if we look at the answer in two periods. Really, not so long ago, maybe 15, 20 years ago, the average survival was about 3 to 3.5 years. And then over the last 15 years or so, with the introduction of the high-dose chemotherapy and also the newer agents that Dr. Ramadan talked about, the average survival has improved to something more like 5 to 6 years, I would say. Dr. Ramadan will correct me.
No, I totally agree. I guess the management of myeloma actually has evolved over the past 10 years. And for a long time, we only treated those patients who are eligible for stem cell transplant with this procedure. But we know that it is a disease that affects patients who are not eligible. So about 50% of patients with multiple myeloma are actually not eligible for stem cell transplant. And those who benefit the most from the newer agents, and certainly their survival has improved dramatically with the newer agents. And yeah, so I mean, when we say the median survival is, or average is 3.5 years, certainly, we see patients who are with this disease and, for 10 years and longer. But it's a disease that we also understand a lot about its biology nowadays, and there is a poor risk disease and good risk disease. It depends on the clinical factors and pathology information that we collect at diagnosis, including the chromosomal analysis. Those who have a good prognosis disease, they do a lot better and they survive for so many years.
Okay. So polycythemia rubra vera, is it actually classified as a cancer? And the second question to follow that, if you're JAK2 positive, is there any new treatment protocols? And also, how frequent is it in BC?
The polycythemia, I am a clinician and a pathologist, and I will have to follow the WHO classification. And that's actually classified as a blood cancer. So it's one of the hematological cancers. So we look at it as one of the hematological cancers. Having said that, patients with polycythemia vera, they are at, their survival is almost, the same as those without polycythemia vera if you control the clotting problem, So most of the morbidity and mortality in polycythemia vera is because of the clotting. So if you control the clotting, meaning that you reduce the hemoglobin level at a desirable level, and you give them antiplatelets, you can control the clotting. And if you bring that down to a reasonable level, the risk of the clotting, then they can survive normal. There is always a risk that this disease can transform into acute leukemia, but it happens in a small percentage of patients. Those who transform into acute leukemia, of course, their survival is going to be a lot worse. But it is a malignant condition. That's the way we look at it.
What about the JAK2 being positive? Is there any treatment focused on that?
The majority of polycythemia vera patients are JAK2 positive. About 90% of polycythemia vera patients are JAK2 positive. When you look at the JAK2 inhibitor, it is a medication, of course. So when you give a medication, you get always worried about the side effects, from that medication. We know that polycythemia vera patients can have a normal survival if you control the clotting by just doing phlebotomy, which is basically has no side effects, or you give them aspirin, which is taken by most people anyway, above age of 60. So when you when you compare that kind of what we think it's a harmless treatment by doing phlebotomy and giving them aspirin with another treatment that can give side effects, and not only that, we don't really have experience with the JAK2 inhibitors. They are not approved by Health Canada yet. I'm sure that people are doing studies looking into the effect of JAK2 on the various diseases, including polycythemia vera. But personally, I don't think that the JAK2 inhibitors are going to be really, many people are enthusiastic about using them, because at the end of the day, there isn't really much experience with these medications, as well as there are medications that have side effects at the end of the day. The clinical studies, which was a major clinical study in Italy, has shown that just doing the phlebotomy and the aspirin will improve the survival and prevent the complications, which is mainly clotting in patients with polycythemia vera.
I just wanted to clarify, maybe you want to tell phlebotomy, maybe some people aren't familiar what that is.
Phlebotomy is basically when you go and donate blood. That's what phlebotomy is. So they take about 500 mils of blood. It's the same as when you go and donate blood.
Because in this disease, your body is abnormally making too much red blood cells, so
that's right.
you give it away, you get rid of it. They want to know how rare, like how frequent is it seen in BC?
I should actually, because we've just looked at the numbers of new patients that we see every year at St. Paul's, and I know that we see at least, probably 25% of patients with this disease. But I did not really, I can't remember the number. It's not very common. In my practice, I think there is about 30 patients with polycythemia vera.
Okay. So is the magic bullet drug beneficial?
Dr. Barnett.
The problem at the moment with this disease is we're not collecting that information isn't going to the BC Cancer Registry. It's rather like the situation was with myelodysplastic syndrome until the relatively recent past, and now we are collecting information on myelodysplastic syndrome, and I'm sure the same will be the case for these myeloproliferative disorders. So we will have that information as we go on.
So the BC Cancer Agency isn't following the WHO classification of collecting data on those drugs
in fairness
diseases.
To them, of course, Dr. Ramadan's relatively young, and so he's very up to date with these things. But the classifications are really changed from calling them myeloproliferative disorders to myeloproliferative neoplasms or cancers in the last couple of years.
So this is all hot off the press. So it takes time.
It's red hot off the press.
I didn't mean to ask you a question prematurely. Is the magic bullet drug beneficial for other types of cancers? And the second part of that question, is cure synonymous with remission?
So the slide that we put up for called the magic bullet was probably the best description for this drug, imatinib, which was essentially designed to treat chronic myeloid leukemia. It is also, and it's really designed to be targeted against the particular chromosomal abnormality in those leukemic cells called the Philadelphia chromosome. That abnormality is also seen in a subtype of patients with acute lymphoblastic leukemia, about a quarter of the adults with that disease, and it is also effective for that disease. But we don't regard it as being a curative treatment, even though, as Dr. Ramadan has said, it's really completely revolutionized how we treat chronic myeloid leukemia, and we now have patients who have been on it for 10 years, and some of them, a significant number, we are unable to detect the disease, even with the most sensitive of molecular tests. So some people have used the term operational cure in that situation, which I think is fine. But in the majority, if we were to stop the treatment, we would detect the disease again. There is a study ongoing in France looking at patients who've had a very good response. The disease is undetectable for 2 years, and then the treatment is stopped. And following those patients, and in some, it remains undetectable. The second part of the question is this treatment, imatinib or magic bullet, useful for other diseases? And it is useful for other diseases which have a mutation, not just this Philadelphia chromosome, but one called c-KIT and platelet-derived growth factor. And the group of diseases that it is useful against are called the gastrointestinal stromal tumors. So as a sort of solid tumor, which also has an abnormality which will respond to this drug.
Okay. So do monthly infusions of IgIG impact on CLL?
Sounds like your question.
That's right. The monthly infusion of immunoglobulin, actually we use this in a subgroup of patients with CLL who have low levels of antibodies in their blood, immunoglobulins in their blood. And those patients are at risk of recurrent infections. And when they develop, these recurrent infections, we think that the monthly infusion of IVIG can be helpful. It does actually reduce the risk of infection, especially the respiratory infections, like the pneumonias. It doesn't actually reduce the risk of sinus infection. We see patients with recurrent sinus infection and, they come and they ask about the IVIG. There is no evidence that it does improve or reduce the risk of recurrent sinus infections. But the chest infections, yes, it does reduce the risk of chest infections. It doesn't actually change or improve the survival, but it keeps the patients, especially, older patients, they need, to be admitted for chest infections and stuff. So we do give the IVIG to a subgroup of patients with CLL who have low immunoglobulin or antibody levels and have recurrent chest infections. It's, again, very expensive treatment, It costs around $100 per gram. And you can imagine if someone, gets 100 gram, you multiply 100 by 100, it is 10,000 per infusion.
So should people take their usual high-dose vitamins during chemotherapy? And could those vitamins help increase the abnormal cell growth too?
That's a very common question. The only vitamin that has been, I guess, studied, and there is some evidence that it can make a change, certainly, if I'm talking about CLL, for example, is vitamin D. Vitamin D, there is an evidence that patients who have vitamin D deficiency, their disease will progress quicker and they will need treatment sooner than those who don't have vitamin D deficiency. The problem is these studies, they don't answer many other questions, like how much vitamin D you should take, what kind of level you are talking about. I have patients come and ask me, about mega doses of vitamin D. I really don't think that there is a good evidence to support this at the moment. But the research, I think, is ongoing, and people are looking into, various vitamins. But vitamin D has been the focus, and the green tea. These are the two, I guess, that many people with lymphoid malignancies, ask these questions. I'm sorry I cannot really answer many questions about the vitamins and stuff, because people come with ideas and stuff that they've read on the internet that perhaps has not been proven clinically. So I can only talk about the stuff that it's been studied, and vitamin D has been studied in CLL. So I can't talk about that, but many other questions, I can't answer. What's your take on that?
I think the easy option as a physician is to tell people not to take anything other than what we're prescribing. But that, as I would say to you, that does not imply that we know that what is being suggested is harmful or is not going to be to be helpful. It's just that we don't have the information. Quite often though, we do tell patients coming in for chemotherapy not to take these alternative medications that they're taking up to that point. But quite often though, during chemotherapy, most patients are not really interested in even food, actually, sometimes, particularly with aggressive chemotherapy. So I've not really answered the question. I don't think I don't think there is an answer.
So does a healthy lifestyle reduce the risk of developing blood cancers?
I think because for the majority of patients, we don't actually know what the risk factors were. But having said that, I think in terms of tolerating some of the treatments that we put patients through and their recovery after, then I think it's very important for patients coming into it to be relatively fit. So I think from that standpoint, general fitness is really quite important, and good nutrition, all the good hydration, a lot of sensible things can't do any harm and probably do quite a lot of good in terms of getting patients through. The other thing that gets patients through some of these fairly aggressive and sometimes horrible treatments is good support within family and friends, etc. So there are a lot of important factors that we sometimes forget in terms of patient coming through all of this and being well 6 months later.
Right. The chemotherapy and treatment are part of a whole package treatment, isn't it?
Exactly, yeah.
Do we have any other questions that people would like to ask? So I'll close the session, and thank you for coming on a Canucks night and on a sunny evening. And I'd just like to announce that next session is going to be on Wednesday, June 15th. It's about Let's Talk About Addictions. It's Dr. Alex Chan. He's an expert in this area, and it'll be here at the Hurlburt Auditorium. And I'd like to extend a warm thank you to Dr. Ramadan and Barnett for giving us an excellent overview of blood cancers.